Cerebral palsy. Disease pathology. CP is a chronic non-progressive disorder of posture and movement caused by an abnormality in the extrapyramidal or pyramidal motor system. The damage to the motor system can occur prenatally, perinatally, or postnatally. The area of the brain that is affected determines the type of neuromuscular disability. The alteration in muscle control is related to a neurological deficit caused by a disturbance in brain blood flow. Problems associated with prematurity and low birth weight are related to the occurrence of CP. Factors associated with CP: prenatally, maternal diabetes, Rh or ABO blood type incompatibility, rubella in the first trimester, genetic causes, intrauterine ischemic event, toxoplasmosis, cytomegalovirus, congenital brain abnormality, prenatal exposure to maternal infection, and precipitous delivery are a few. Perinatally, asphyxia, low birth weight, and prematurity are associated factors, and postnatally, infections, trauma, stroke, or poisoning are associated. Signs and symptoms. Manifestations can vary widely from one child to another. A child can have persistence of primitive reflexes, delayed growth and motor development, abnormal muscle tone, lack of progression through developmental milestones, abnormal posturing with inability to maintain normal posture and balance, disturbances of gait such as ataxia and toe walking, seizures, ADD, sensory impairment, failure of automatic reactions, and speech and swallowing impairments. Classifications. Dyskinetic is a disorder in the basal ganglia. It's characterized by slow, writhing, uncontrolled, involuntary movements involving all extremities. Spastic is the most common type. It affects the cortex, characterized by increased deep tendon reflexes, hypertonia, flexion, and sometimes contractures. Ataxic affects the cerebellum, characterized by loss of coordination, equilibrium, and kinesthetic sense. Rigid is rare. Rigidity of both flexor and extensor muscles, tremors apparent at both rest and movement. It's associated with a poor prognosis and with deformities and lack of active movement. Mixed is more than one type. Common combination is spastic and dyskinetic. Population affected. More than 500,000 Americans are affected. The rate of CP is 3.6 out of 1,000 live births. Infants with the lowest birth weights, weighing less than 2.2 pounds, may be at increased risk of CP because of intracerebral hemorrhage or periventricular leukomalacia. Increasing survival rates of premature infants has also resulted in an increase in the prevalence of CP. Almost 60 out of 1,000 premature infants weighing less than 1,000 grams are affected by CP. Prognosis. Half of children with CP have other disabilities such as epilepsy, a cognitive disability, learning problems, poor attention span, hyperactivity, hearing or visual impairment, and emotional problems. Intense movements that cause a high expenditure of calories along with feeding challenges can lead to a calorie deficit and poor nutritional status. The goal of managing a child with CP is early recognition and intervention to maximize the child's abilities. Diagnosis is usually not made before the age of 2 years old. Repetition of motor activities facilitates development of new brain pathways through alternative receptor sites and enhances appropriate motor function. The child may be intellectually intact. A multidisciplinary healthcare team approach is necessary to meet the many needs of the child. Medical treatments consist of baclofen, which is a skeletal muscle relaxant. It's administered via an infusion pump to treat severe spasticity. Benzodiazepines are also used to treat spasticity. Botox is used for non-ambulatory children to help with comfort and care. And close monitoring of the child for infections and the pump for malfunctions is required. Nursing interventions. Reinforce physical therapy exercises to strengthen and help coordination of muscles. Encourage parents to be active in child's daily physical and occupational therapies. Observe and record the child's response to physical therapy. Determine the need for special equipment for reading, writing, eating, and mobility. Monitor the child for chronic pain resulting from surgical procedures and other interventions. Monitor the child's developmental level and cognitive abilities using specific and sensitive developmental screening tests, both on a routine basis and as needed. Encourage early interventions and refer for early intervention community programs. Communicate and interact with the child at the child's functional level, not chronologic age. Teach the family principles for providing a safe environment. Have the child wear a protective helmet and pads if falling occurs frequently. Implement bedside seizure precautions. Provide safe toys that are appropriate for age and development. Position the child upright during and after meals to prevent aspiration from gastroesophageal reflux. Use the child's usual mode of communication, such as flashcards or talking boards, to facilitate communication. Refer child to speech therapist, and encourage and reinforce speech therapy techniques. Journal article number 1. This article provides guidance about what works and what does not work in the management of CP. CP is the most common physical disability of childhood, but the rate and severity are decreasing. Epidemiologists propose that the reduction in incidence and severity is likely due to a combination of comprehensive obstetric and neonatal intensive care interventions. The most notable breakthrough in the field of CP research in the last decade have been made in the area of prevention. Magnesium sulfate before delivery of an infant less than 30 weeks gestation prevents 30% of CP. Corticosteroids decrease intracranial hemorrhage and thereby also act as an effective neuroprotectant and have become the standard of care. Green light allied health interventions supported in this article are acceptance and commitment therapy, action observations, casting, constraint-induced movement therapy, environmental enrichment, fitness training, goal-directed training, hippotherapy, home programs, literacy interventions, mobility training, oral sensory motor plus electrical stimulation, and pressure care are a few. Journal article number 2. This article discusses CP and its effects on development. CP is one of the most frequent causes of motor disability in children. CP is a group of permanent disorders of the development of movement and posture, causing activity limitations. The diagnosis of CP is mainly based on motor function and posture disorders that occur in early childhood and persist until the end of life. They are non-progressive but change with age. Motor function disorders are frequently accompanied by other dysfunctions such as sensation, perceptual, cognitive, communication, and behavioral disorders, epilepsy, and secondary musculoskeletal disorders. Proper management of comorbidities can improve the development of children who have CP. Growth and development impact on the 5 stages of childhood. The child's development can be impacted in numerous ways depending on the severity and extent of the brain damage. Therefore, knowledge of typical development is essential to compare the atypical development of children with CP. The gross motor function classification system is used to categorize different levels of functioning within the disorder, with level 5 being the most severe and level 1 being the least severe. Level 1 walks without limitations, while level 5 is non-ambulatory and has to use a wheelchair. In the infant, the level 1 child is able to walk, however, they don't typically start walking until 18 months to 2 years, so they're a little delayed there. While the level 5 infant, their voluntary control of their limbs is limited and they require assistance in sitting up, rolling over, and holding their head up. And they are unable to walk, so they are affected there. Growth and development in the toddler. The level 1 toddler can sit easily while holding objects in both hands without assistance and walk as a preferred method. Level 2, they can move in and out of the sitting position. They prefer to crawl on hands and knees and cruise along with furniture and walk with an assistive mobility device. Level 3, the crawling is the preferred method of moving around. Walking for brief periods can be done with a walker or with assistance needed for turning. Level 4, children can now sit up alone but need to use their hands for support to maintain their position. In level 5, children continue to have extremely limited mobility. They need assistance in all areas of movement. For the preschooler in the level 1 category, they are able to sit down and stand up without support, sit on the floor, get up without assistance, and climb stairs. They're beginning to run and jump, so they're not as much affected as the level 5, where there's not much of an increase in function from the previous level as a toddler. Whereas level 2 could sit in a chair or on the floor and use their hands freely. They move into a stand now without as much need for a stable object to hold on or push. They're able to walk for short distances without assistance. For the school-aged child, at level 1, they can run and jump, climb stairs, and walk without any type of assistance, but their speed and balance and coordination are somewhat limited. For the level 2 child, they need help with carrying objects, climbing steps, and walking on a floor or an inclined surface. And we'll go down to level 5. Their mobility is still extremely limited, although some children can use an electric wheelchair on their own. Children in this age group are still dependent upon others for movement and need extensive adaptations to maintain head and body alignment. For the adolescent and the level 1 category, they're able to walk on all surfaces, indoors and outdoors. They can run and jump, but their balance, speed, and coordination are still somewhat limited. They can participate in any physical activities based on their abilities. Level 2, they're able to walk in most settings with mobility choices based on personal preferences, so things need to be kind of tailored to them. They will likely need a handheld mobility device for school or work and a wheelchair for longer distances. For the level 3, they can walk upstairs with a railing as long as they have assistance. They will, however, need help with transfers and a seatbelt for support and balance while sitting. Walking is facilitated by a handheld mobility device, but at school they generally use a powered or self-propelled wheelchair. The level 4 adolescent self-propelled wheeled mobility is required in most settings along with adaptive seating. Generally, 1 or 2 people are needed to help with transfers, although the youth will be able to support their weight to assist with standing transfers. And the level 5 adolescent, a manual wheelchair with assistance is required for mobility, although self-mobility may be attained with very extensive adaptations for control and stable seating. Arm and leg movements are difficult to control, as well as maintaining head alignment. Youth in this age group may require a mechanical lift for transfers, along with physical assistance by 1 or 2 persons. Residual effects. So individuals with very profound CP who have severe reduction in postural control may experience compression of internal organs due to soft tissue contractures and asymmetrical posture, severe scoliosis, and in these cases, life expectancy may be reduced. Post-impairment syndrome occurs in adulthood and comprises a combination of several or all of the following: increase in muscle weakness, fatigue, pain, bone deformities, overuse syndrome, or repetitive strain injuries, and or degenerative arthritis. Musculoskeletal abnormalities, which do not result in discomfort during childhood, frequently start to cause pain in adulthood. Abnormal approximation of joint surfaces can lead to early development of osteoarthritis. Limitation in muscle strength and alterations of movement patterns mean that people with CP are at risk of developing overuse syndromes. Independent walking, both with and without the use of walking aids, is known to reduce significantly in adulthood, with a number of individuals losing the ability to walk independently and an increase in the use of wheelchairs. The abnormal strain put on joints of individuals with CP and the fact that bones have grown under this abnormal loading frequently leads to joint deformities, mainly in the spine and lower limbs. These include patella alta, hip displacement, scoliosis, cervical stenosis. Joint pain is a common occurrence even in young adults. It occurs as a result of the abnormal strain on the joints. So my original NCLEX questions are: what risk factors are associated with cerebral palsy? A, prematurity, asphyxia, maternal diabetes, genetic causes, low birth weight. B, genetic causes, low birth weight, stroke, epilepsy. C, low birth weight, maternal diabetes, flu vaccine. Or D, toxoplasmosis, rubella in the first trimester, or herpes zoster. The answer is A, prematurity, asphyxia, maternal diabetes, genetic causes, and low birth weight. Question number 2, what is the most common type of cerebral palsy? That would be D, spastic.